So I am a neonatologist, and I always even share with the parents that I meet, my role, my mission is to save baby's life. That's why I went to medical school, I did my fellowship and everything. So even when I meet babies before birth, I have in my mind that I need to counsel family about a plan of care once the baby are born. As you can imagine, I've been involved in prenatal diagnosis. In our hospital, we have a very, very, very large center for prenatal diagnosis. And we, as a neonatologist, we are called on board to speak with the family anytime there is any kind of problem with the babies. Babies with congenital diaphragmatic hernia, cardiac disease, any kind of problems. So at this point, many years ago, I was involved with families who were expecting babies with what we call life-limiting conditions that are not amenable of medical or surgical treatment, and therefore these babies will be born and have a very short life. And I met with families who wanted to continue their pregnancy and see their baby being born. And so I got involved with them as a neonatologist. And for some reason, in all my hospital, I was the neonatologist that I was more involved than others with this kind of pregnancies. And therefore, I tend to primary those babies once they're born and take care of them. And so this question raised, is there any medical treatment for these babies? Because I am a neonatologist, I'm a doctor, so what's my plan of care for these babies? It's not that they are born and they die right away. These babies have a life. They live for minutes, hours, weeks, months, sometimes for years. So, you know, I had this problem because I was involved more and more with these babies. And so, along with these babies, with their families, and with what we know in medical science, we try to put together over time a program. First of all, you know, I want to sort of define which are the babies who are candidates for the comfort care. And after the talk of today, maybe I should change my criteria. But anyway, so in general, you know, each child is different. And, you know, anyway, we'll talk about this later on. So in general, I identify two big categories. One is babies affected by condition, for what we know, non-compatible with life beyond hours or days, with or without ventilatory support. You know, I graduated in 1981, so I saw many babies being born, and I saw also many, many babies in mechanical ventilation for days with this kind of condition, and I saw that their life was not actually prolonged because of the life support. And maybe with the advance of medicine, I will change my criteria, but for now, I keep this one. Also, we encounter other babies, babies with trisomy 13, 18. Sometimes they are affected by very, very severe anomalies on top of the fact that they have an extra chromosomes. And so for some of them, also their life can be very well limited. Also, we have babies born with extreme prematurity, born before the time of viability. And in my program, also welcome babies who have been in the NICU, very, very ill. They can become terminally ill, and so we want to accompany them to the last day of their life in you know, being aware of the fact that they have dignity, and so to create an environment for them, for their family, proper. Did you go through? It doesn't go through. Help. Okay, so obviously I'm not the first one who think about neonatal comfort care. There are many, many works in literature. Many are about perinatal hospice experience. In the United States, there are more than 100 groups of perinatal hospice throughout the country. But most of them are founded by obstetricians, and they're very focused for the pregnancy care, for the delivery room. Not much is written about what happens to the baby, to babies once they're born. There are many articles about decision-making in the NICU when a baby becomes terminally ill. So what do we do? How do we switch from intensive care to comfort care? And again, not much is written about concretely which guidelines do we have to accompany this baby in a comfortable way. There are many, many articles about pain management. However, being comfortable is much more than being pain-free. And therefore, I really found a lack of resources in literature. It's not just my opinion. As you can see, okay. As you can see, I just mentioned here a couple of important articles. The first actually comes from Spain, from Europe. Ballinger in 2012, they did a huge review of more than 1,500 articles. And basically, they identified 30 clinical articles, but no one of them had a quantitative result. So really, we don't know what to do with these babies to make them comfortable. And Brian Carter, who's pretty much famous in the United States because he is an expert in pediatric palliative care, says the same thing. I look up literature to know whether in Europe there are some experience, and I found an article in Portugal in guidelines established in the United Kingdom. What I did not find, and maybe you can help me if you know about that, about experience of hospital where they run a program of neonatal comfort care with guidelines and they have outcome data. This I didn't find. So that's why I start more or less on my own. Maybe, you know what, you should advance the slides for me because this doesn't work. Anyway, here we are. So one of the saddest things to me is that, at least in the United States, when we use the expression comfort care, basically means don't do anything. Let the baby die on its own. The baby is not taken care really, is not fed, is abandoned. And so when I start thinking about what should I do for these babies, and I thought about the words comfort care, for me, comfort means comfort. And so I thought I need to develop guidelines to make a baby comfortable. And so I tried to study how a baby is comfortable. Okay, and well, I skipped one slide, but basically the slides said that I want to set up guidelines which are based on discomfort, but also they can be standardized, so can be followed by many hospitals, but also very individualized, very personalized. Each baby is different. As you remember before in my list of criteria for inclusion for the comfort care program, there is such a wide spectrum of different diseases. And so the care should be individualized to the same patient, even with the same disease, because each child life is really different. So how do we achieve a state of comfort for babies? Now, this is a study done on normal newborns who are undergoing a heel stick. If you look at the two figures, you see that the white column on the left represent the number of babies being kangaroo, skin to skin with the mother, while the nurse obtained the heel stick. The grimace is much diminished, and almost no one of them cries. On the right, you see how the heart rate of babies being kangaroo by mom while the healing stick is done, the heart rate remains constant. They're not even upset, which means that just the bonding, being held by the mother, the skin-to-skin contact, is like an anesthesia method. It keeps them quiet and happy, help them achieve a state of comfort. The same can be said for feeding. I don't know why this instrument doesn't work that well. Push hard. Okay. Oh, no, disappeared. Maybe, you know what, if someone does for me, okay, good, next. Okay, so these are also healthy full-term babies, 180 of them undergoing venipuncture. On the figure you see pain scores, and the pain score of baby being breastfed is much, much lower than babies who are just held by the mom. There is also an interesting method by an Italian doctor, Dr. Bellieni, described as multisensorial saturation for infants' pain. It is called the 3 T's. So you make the baby suck sugar, something sweet, you massage the baby, you speak in a very sweet way, so in order to attract the baby attention, and they measure the pain score of this baby undergoing a painful procedure such as, you know, heel stick or something like that, and the babies are more calm, they don't cry. Now, I understand that these are healthy babies undergoing painful procedure and very different than babies who are terminally ill, but still we are looking for some guidelines in order to achieve comfort. Okay. The other thing is I found in literature that not these methods like bonding with the family, feeding the baby, etc., is facilitate comforts for family and also for professionals, for nurses. And therefore, it seems to me that this kind of comfort should be achieved with the whole team working around the baby. Here are my guidelines. They're very, very simple. So I define comfort as the satisfaction of basic needs. And so in order to be comfortable, a baby needs to be welcome, therefore to bond with the family, be warm and clean. Therefore, we facilitate kangaroo care, baby being swaddled. Baby should not hungry or thirsty, and baby should not suffer pain. Now, in my discussion with the parents, when I propose the comfort care plan before birth, one of the bigger questions of the parents is my baby going to suffer? Maybe, you know, I cannot see that. Maybe I cannot go through this because of the pain of the baby. And I always tell them, no matter the diagnosis, you are going to suffer because you're going to hold your baby who's going to have a short life, and we cannot do so much about that. But babies born with life-limiting condition, and I see many, many of them. I probably went through more than 200 cases up to now. They tend not to suffer. As Fran was saying this morning in her video, this baby, they tend to slip away, and occasionally they do have a sort of, gasping or discomfort, and with intranasal fentanyl or morphine drops, the pain is quickly relieved. But the vast majority of my experience is that the baby becomes very quiet, stops breathing, and then the heart stops. And so it's a very dramatic, very painful, very intense for all around them, especially for the family, of course. But the baby himself or herself has a peaceful experience. This is just the orders for nursing at the admission of the baby. And so we do evaluate the baby. We take vital signs a couple of times a day. We see if the baby, how much he or she feeds, if the diaper is wet or not. So we do evaluate their status. We want them to be hydrated. We want them to be comfortable. But obviously, we don't do extra blood drawings as a routine. We do have blood drawings if we need to make sure about the diagnosis, obviously. But more than anything, when we round with our team, the medical and nursing team, really the focus is how this baby can be comfortable. Okay. Now, let me just go through clinical cases because I think that's the best way to share what we are doing. Okay, so I show you many pictures. I have permission from all parents, actually. They are very excited to be shown around. And by the way, I make this comment before showing these pictures. If you didn't know that those are pictures of baby who are actually dying, you would never say. Because one thing that I learned during all these years is that before that there is life. And the moment of the birth for these families is the moment of joy, the moment of celebrating the birthday, the day of birth of the baby, because life is now, no? And so, for example, this is a little girl who lived 4 hours. Many years ago, this happened. The little brothers knew about the condition. They were prepared during the pregnancy to welcome the baby. And as you can see in the picture, they are so excited. Finally, she's out, she's there, she's alive, she's ready for them to embrace her. The parents told them, your sister is going to live a short time, therefore tell her everything. And see, they are talking to her. I like the experience of this family because many parents ask me, maybe I shouldn't tell anything to the other siblings, maybe they should not know, maybe they should not see the baby, it's going to be a trauma for them. And this family, among many others, taught us quite the opposite. So this is 7 years later. I do once a year in my hospital a workshop to teach this practice for doctors, nurses, social work, everybody involved in neonatal comfort care. And I invited that mother to give her witness as a parent, as we're doing now here in this conference. And she told me, I want my boys to come. They want to say something. And so I invite them, and was very moving. Their experience as, little teenagers. They saw the sister for 4 hours, and their life was changed. They speak about her, as she was around, as in a certain sense she is. And they basically, the family put up a bereavement center, and they also counsel other young teenager or kids who are going through right now the same experience. Now, bonding should be there even where parents are not present. Occasionally, probably 1 or 2, 3 times happen, only parents don't want to be there as the baby is dying in the NICU, or maybe they live far away and the baby is dying, and so no baby in my hospital dies in bed. If the baby is dying, is being held, could be the nurse, could be the doctor, could be the resident, could be anybody, could be the clerk, because, they need to be bonding in that, important moment in their life. Warmth, another important need for a baby. The baby needs to be warm. So this is another example. This is a family who lived for many, they're from Minnesota, but they were in Brazil. And they were diagnosed on the 3rd baby with, they saw some problems. They came back to the United States for the diagnosis, and they were diagnosed with a little girl with trisomy 18 and a very severe cardiac condition and some other abnormalities. They came to my hospital for the final diagnosis. We make together a plan, possibly for comfort care when the baby was born. And this was still, early in the pregnancy, and so I was expecting them to come in a couple of months. Well, after 2 weeks, they came back. She actually, to tell you the whole story, she delivered in the car while the husband was driving her to my hospital on the George Washington Bridge, was escorted by policemen, come to the hospital. The baby was this small, 2 pounds, and we don't want to put the baby in the incubator, and so she did kangaroo care. This baby lived for 24 hours, and she was kangaroo by mom and dad. She was never left alone. Then grandparents came with the other children, so the whole night was a big celebration. Again, we are there as a professional. We want to make sure, is the baby warm? Is the baby cold? Do they need anything? But we kind of observe from the outside in order to leave to the family the total bonding and the privacy they need to experience with this little baby. Now, this is a slightly different case, the case that really taught me so much that before that there is life. This is a woman, her third child. She had some complications. She has placenta crida, so she needs to undergo C-section. And in that case, in the OR, all our comfort care team was there. They, our obstetrician, very, very generous. They allow in the OR to have the father of the baby and the grandmother. And then was all of us there, you know, properly dressed. And here the baby has been delivered. It was a baby with limb body wall complex. All of us were there, and we just grabbed the baby from the mom belly, and we put the face of the baby close to mom's face, so then she can feel it. This is the beautiful boy. He had a short life, about 30 minutes. But so the little sisters choose the outfit, and his heart is still beating, so he was still alive at this point. The sister wants to have the picture with him. And in the, let's say, recovery room of the mother, we gave like a private recovery room, the whole family was there. This was our team, friend, myself, social worker, a young nurse from Italy. You see Manhattan on the background through the windows, and the little boy there with us. Yes. And then we did something very not allowed in the hospital. We turned on candles to celebrate the birthday. At this point, you know, I can disclosure, they cannot fire me anymore. But the sisters, because we asked the family before, what do you want to do? You know, baby life is going to be very short. Tell me, whatever we can do, we'll do. And so they came with the birthday cake, and the sister really wanted to turn on the candle, so we just did it. On the background, you see mommy holding the little boy. Okay, this is, can you see it? Yeah. So this is a case very interesting to me, shows to you the assessment of the baby after birth, and also the transition from intensive care to comfort care. This baby was prenatally diagnosed with AV canal and hypoplastic right heart and esophageal atresia. So was admitted to the NICU and went through surgery for esophageal atresia. And then we came to know more about him. We came to know that he was deaf, that he was blind, he had bilateral coloboma, so was diagnosed with Charge syndrome. And also he was diagnosed with severe immune deficiency. At this point, with all these big diagnoses on board, we sit down and rediscuss with the family, should we go into cardiac surgery? You know, we explain that this baby with this very severe case of immunodeficiency plus the whole rest probably would have short life, and so go to a single ventricle repair will be, you know, probably a way that he will suffer a lot, and the outcome was not so good. So we had several discussions. And really, the parents said, you know, doctor, we trust you. What would you suggest? And so I said, listen, Henry is living, is breathing, is feeding. Why do we don't follow him? And so he went home with hospice care with his nasal cannula. Parents learn how to feed the baby. We love to feed the baby through a bottle, through their mouth, because also literature prove that if the baby can suck and feel the taste of the milk is much better, it's much more comfort. But in this case, we evaluate the baby was a very high risk of ingesting, and so we went home with the NG feed. And his life was relatively short. He lives for a few weeks at home, but he really enjoys life at home. And, you know, I like Harry's story because it tells you that you have to follow the baby situation. The baby is telling you which way it's going. And in the discussion with the family, we bring this about all the time. And then we decide with them the plan of care. This is another case who helps me explain to you a little bit more about the nutrition that we use and also the unpredictable length of life. The little boy in mom's hands was diagnosed prenatally with A. lobar holoprosencephaly, which is a big term to say that the baby has, instead to have two hemispheres, has only one, with a very thin cortex of the brain, and basically the entire head full with basically water. The baby had no eyes, no nose, and he has a little mouth. And when you read on books, medical books, they say this is incompatible with life. It's lethal. As usual, when I spoke with these parents during pregnancy, I said, listen, that's what I know. That's what I read in books. I saw some of this baby being born and die within the first couple of days of life. And I said, let's follow him. Let's see what happened. We are, ready for everything. So the little baby was born, was crying, was vigorous, was tiny, petite, 3 pounds, really tiny. And, but then after a few hours, it was so alive and awake. So I called my feeding specialist. She comes, and the baby had also cleft palate. And so she put together a sort of device, which is like a big syringe with a little dropper on top. So the parents learn how to feed him drop by drop, every hour, every 2 hours. And we set with them what's the minimal amount of milk in order for him not to be dehydrated and to be comfortable. And so we expect the baby to, to have 2 or 3 days of life, a week or so. So he made it through the NICU, to the postpartum admission. He was in postpartum with mommy, never came to the NICU. We didn't want to separate the baby from the family. And so we send them home with the hospice support. After 2 months or so, I received a telephone call from mommy, and I asked, how is the baby? And she said, well, he's growing, he's thriving. And she asked me to come back to the hospital to do the hearing screen, which we didn't do because I didn't want to do extra tests. The poor baby, his life is going to be short. Why bothering, with tests or things like this? And she told me, babies no eyes. I want to know if I communicate to him. And so I said, come. You wouldn't believe it. The baby passed the hearing screen. I don't know how, but he did it. So go ahead. Then they moved to California. So we have been in touch. This is father feeding the baby with this special device. And the baby's been thriving along. And next slides. He's now 2 years old. He has a baby sister. And so now they put a G-tube to make it easier for him to be fed. So again, this is our method. We follow the babies. If the baby is strong, lives, we feed them, we support them, and then we learn so many things about the natural history of these diseases. Usually, these babies tend to die early because their brainstem is very malformed, not working well. With him, it was not the case. And so he's one of our little heroes. Okay, go ahead. Again, our medical plan, follow the baby. This was also a very beautiful story. So this couple was expecting twins. One of the two had hypoplastic left heart. Both of them were born premature at 33 weeks. And hypoplastic left heart, we heard today a lot about that. The prognosis is not good when the baby is born premature. And so the parents decide not to undergo surgery. So the so-called healthy baby ended up in the NICU on the CPAP and NG feeds. And this little boy, the one with hypoplas, was much smaller, but basically was breathing well and was kangaroo day and night by mom. They also fed him with a little syringe. We gave them the schedule, the amount of milk not to get dehydrated. And so basically, baby was kangarooed and fed and was okay. Because it was premature, his ductus arteriosus did not close for 2 weeks. And so he was around for more than 2 weeks. Also, what happened after 2 days, mom developed a liver hematoma, a consequence of the C-section, and she needed to be transferred in another building to the adult intensive care, and we didn't want to detach the baby from mommy, And so our nurses did an extraordinary job. They basically brought the baby there, and one of the NICU nurses stayed with mom 24 hours on 24 hours to allow her to hold the baby and to stay with the baby and to feed the baby, intensive care unit for adults, which was an extraordinary, go out of your road to help this family. So are the picture of the baby being fed, sometimes with a bottle, sometimes at the breast, sometimes with a dropper, sometimes with an NG tube. Next. So the other brother was in the NICU, so we had the two of them together in the NICU, the two of them at the maternal side. So we tried to keep the family together. And this is was the day before they went home with the bigger boy, the healthy boy, and the little boy, the one with hypoplast, died that night. You can see his color was going down. Now, this case helped me also make you understand that as a physician, every day we did round on this baby. I examine this baby every day. We evaluate, the fluid status, the diaper, everything, and it's very challenging because the parents are asking, is the baby going to die soon? What do you say, doctor? And with this baby, I had no oxygen saturation monitor, I have no blood gas, I have nothing, no blood pressure taken. So everything, my evaluation was my clinical evaluation, and I was able to actually pinpoint the day before this happened that this liver was becoming big, it was breathing with a little more of effort, it was a little more gray, and so we were ready for that moment. We took beautiful pictures, and he peacefully went. Yeah. Now, very, very important, evaluation of the baby after birth. Prenatal diagnosis in our hospital is excellent. We have 93 to 94% predictivity, prenatal and postnatal diagnosis, but some, I don't want to say mistakes or errors because it's no fault of anybody, but differences, because it's different to see a baby through the ultrasound machine and having a baby in your hands, right? So I give you a couple of examples. This was a baby who was prenatally diagnosed with trisomy 21, tetralogy of Fallot, and lobar holoprosencephaly. Now, neither one of these diagnoses is life-limiting, but when you put the three together, you are concerned that this baby may be in trouble. Therefore, we did discuss with the family a possibility of comfort care, but again, as usual, we say, you never know. Let's see what happened with the baby. Baby was born. Next. And the diagnosis of trisomy 21 obviously was confirmed, as well as tetralogy of Fallot was a pink tat. So the baby was not even cyanotic. And what we thought was holoprosencephaly by fetal MRI, it became to be just a big arachnoid cyst by newborn MRI. And so arachnoid cyst per se has not too much significant from a neurological point of view. Next. So therefore, the baby was actually able to nipple, went home at 2 weeks of life on full breastfeeding. You can see him at 2 months, 1 year of age, and the next is at 5 years, he's in the kindergarten. So he's a little boy with Down syndrome, but other than that, he had tetralogy repair at about 9 months, very uncomplicated, and he's a happy boy now. He's about probably 7 years old now. Next. This also a case somehow similar to the one that Meredith, although less striking. So this was an infant diagnosed with severe renal dysplasia, and we are very worried about pulmonary hypoplasia because the fluid was really, really minimal. He had oligohydramnios for a while and then became anhydramnios. This mom was followed by another hospital, and then she came to deliver in our hospital pretty much at the last moment. So I spoke with her during labor, and I explained to her the comfort care plan. And as usual, I say in the very end, Mom, you never know. Let's follow your baby. So, next. So the baby was born, was screaming of his lungs. No respiratory support needed. It was a full-term baby, although he had indeed renal failure. His creatinine went up to 5 after 3 days of life. He would not, I can compare him to a baby almost with no kidneys. I mean, he was making a little bit of urine, but creatinine 5. So we spoke with the nephrologist, we spoke with the pediatric surgery, they put a PD catheter, a peritoneal dialysis catheter, went home, mom learned how to manage, is now about 1 year old, and he's going to get his transplant. But again, you know, we follow the babies. Next. I want to tell you a little bit of the outcomes data. 5 minutes, perfect. These are kind of old because the one that I publish are outcomes data of 49 infants from 2008-2011. All these parents were counseled by our team, but 4 of them were not confirmed. The diagnosis was not confirmed after birth, so the outcome data is about 45 babies. Go. Now, you can go to the next. So 28 parents agreed about comfort care, and 17% asked us to try to do intensive care no matter what. And as the numbers are very small, but I try to put together to match the diagnosis. Now, the let's say the outcome of this study is not to determine, absolutely not, the outcome of babies with the kind of anomalies, because the numbers are small. I just wanted to show to you in a center like ours, with the comfort care in the way we do with our guidelines, what is the outcome of this baby compared with others who undergo intensive care. Next. So the results is that the average survival in the babies that I treated with comfort care was from 1 to 164 days, and babies with similar diseases who underwent intensive care, average survival was from 1 day to 123 days. And so what I'm proud of is that the comfort care, as we do, supporting the baby, feeding the baby, keeping them warm, the bonding, and all of this, somehow gives to the baby the possibility to survive similar to the one that they would achieve with intensive care, but with much more comfort. Next. Now, I'm looking now to put together the data from 2011 up to now. I have many more babies, and you know, maybe next time I'll tell you about that. The other thing is we always talk about comfort care, but I do want to make sure I make this baby comfortable. Therefore, we have pain scores, but as I said before, to be comfortable is not just being pain-free. Therefore, we thought to ask parents. We gave anonymous questionnaires, and we asked them detailed questions and also open questions. How do they see the comfort care, and what was their opinion? Was the baby hungry? Was the baby thirsty? Was the baby suffering? Was too much light? Did professional care for your baby? So many questions. And I want to show to you the preliminary results. So we enrolled 23 families, and we have 30 questionnaires back. And what is remarkable for me is that the number of mom and dads are almost the same. And I don't know why, but when you read in literature questionnaires about similar subject, all the moms usually answer. We have high incidence of daddies answering, so I don't know, that's remarkable to me. Anyway, the vast majority of parents really thought that the baby were comfortable, and especially they did have the opportunity to feed their babies, to take care of them, to be father and mother. I also asked them, how would you describe comfort care? So one parent wrote, pure love, unadulterated longing for goodness. Another one, an umbrella that tries to protect the baby. Another one, a band that helps healing. A beautiful calming corridor between this world and the next. And many, many other beautiful comments. So this is the team. I am the medical director, but I am also full-time neonatologist. Fran McCarthy, who spoke this morning, is my clinical care coordinator, and we just hired a social worker completely dedicated to them. What is good, since we are based in our big hospital, is that, as in the cases that I showed before, we are ready at delivery to offer the comfort care, but if by any chance the diagnosis is not correct or the prognosis is not correct, so the baby, seems to want to leave, we just change our uniform and we become intensivist. So we can continue the care with them, which I think for parents is very, very important. Then we have, sorry, go back one. Then we have some other people that I mentioned already before, which are feeding specialists, child life, a psychologist, and chaplaincy. Next. This is just a quick pictures of the memory that our child life specialist does for parents to take home as a memory of the baby. And then my last slides is this frame. I asked the parents to take a picture of this frame. She embroidered and she put on the crib of the baby. And she said, it says, "You are loved." And I was so inspired because, in order to do all of this, you have to put so much effort, so much hours of work, especially to make sure the diagnosis is right or wrong and to choose the right path. And I really thought that this phrase describe the reason of our effort. We want to help those parents to love their children. That's their goal. And so we put all this effort with this motivation. And with this, I think I'm done. Thank you.